Welcome to the Menopause and Cancer podcast, where we speak with cancer patients, survivors, and incredible experts in their fields to help us find solutions to our symptoms and ideas to improve our health. Today, I want to discuss with you if your bones are at risk after your cancer treatment. Many cancer survivors experience bone loss due to treatments that affect their hormones and bone density. And so in today's episode, I really want to break down with you to understand if you are at risk, what to do, how to find out, who and what can help. Our amazing expert of today is Dr. Olivia Hum. She's a GP specialising in women's and sexual health. She's an accredited British Menopause Society expert. And most recently, she has contributed to a brilliant article in The Guardian, Feel It in Your Bones, Taking the Pain Out of Osteoporosis, which was a really brilliant article that she has contributed to. So we're going to cover how cancer treatments can impact your bone density, when to get the bone density scan, who qualifies, what medical treatments are available, and we're also going to talk about holistic approaches, diet, exercise, other lifestyle adjustments, and do listen to the end where Olivia and I talk about how heavy our weights are that we try to do our exercises with. Anyway, enjoy this episode, get pen and paper out. I think there's lots to learn and lots of doors to knock onto maybe after this episode to get the answers that you need and deserve. Thank you for joining me today, Olivia. How are you?
I'm fine. Thank you so much for asking me to be on your podcast.
Olivia, we've just talked about one of our lovely people that joined one of our workshops, and she's come to see you in your clinic. And I know you look after a lot of cancer patients. Tell me, do a lot of them ask you about their bone health, or do you have to tell them that bone health might be an issue after cancer treatment?
So you're absolutely right. For a lot of women, this has really never been mentioned to them at all. And one of the really brilliant things about the increased focus on menopause and on women's health has been that actually women are starting to think about bones a lot more. So I think it's really changing. But I know from the times I've talked to you about it, that actually the information that women are getting all over the UK is actually pretty inconsistent, and the treatment they're getting and their access to bone density scans is actually very variable depending on where they live.
Sometimes when I run a workshop, and obviously not being a medic, I can only say to people, be aware of this or ask that question and sort of help people have conversations with their doctors. Most people do say to me, I had no idea bones might be negatively impacted by my treatment, by chemotherapy, by any of my other treatment. And many of them are quite young. And that's always upsetting because from talking to you, there is much we can do, right? To look after our bone health. We just need to know it might be a problem.
You're absolutely right. So this is where it will. So a lot of women don't think about their bones because obviously we think that bones are just these things that sort of hold us up. They're not, but actually bones are constantly dynamic. They're always changing. And inside them, what's happening is that your bones are constantly being broken down and rebuilt. And that's before the menopause, that's pretty stable. So you've got these cells called osteoclasts that chew up all the old bone. And then you've got osteoblasts, and these build new bone. And when you are young and you're growing, there's lots and lots of new bone being formed. But you reach your peak bone mass in your 20s, and then it's sort of stable from then until menopause. So you've got this constant process of breaking down, building up, breaking down, building up. But after menopause, so either menopause that's a result of cancer treatments, early menopause, or after menopause, or after some chemotherapy, what happens is this whole balance changes. And suddenly the osteoclasts start breaking down the bone. And this can happen really rapidly. And we know that after menopause, women lose over 10 years, they lose about 8 to 10% of their bone mass. And this doesn't seem much of a problem at the time because you can't feel it. It's not something that you'll get any symptoms from. But when it is a problem, is later in life. And what we know is that this results in women having fractures. And so the figure that really amazes women is that 50% of women will get a fracture, an osteoporotic fracture at some point in their life. And that is a huge number. But we know that this risk is increased by certain types of cancer treatment.
Wow. And what are these cancer treatments? So let's really go into whatever age we are. People have different cancer treatments. We obviously talk to an audience of different types of cancer. So who might be affected from worse bones than even the shocking 50%? statistic that you've just given us.
Yeah, no, absolutely. So anyone who's been put into an early menopause, so anyone who's been put into a menopause before, so an early menopause is before 45, a premature menopause, what we call premature ovarian insufficiency, is before the age of 40. And this means you just have you have fewer years of estrogen than everyone else does. So if you go through menopause at 39, you are going to miss out on, if we say the average age of menopause is 50 or 51, you're missing out on 11 or 12 years of estrogen. So your bone density decline is going to start earlier. So as it goes down and down and down, the time that it gets risky, the time that you might fracture, is going to happen earlier than other women. So it may well happen for you at 60 rather than 80, for instance. And that is something that we know, this decline in density. So density is like the thickness, the toughness of your bones. We know that that can actually be mitigated if you're given treatment soon enough. So, and that is particularly an issue with any, and especially particularly with breast cancer patients, because we know that some of the younger breast cancer patients are being given treatment that puts them into an early menopause. So either chemotherapy or these things called GnRH agonists, which are the medications, so things like Solidex, which put you into an early menopause. And these are particularly bad for your bones. And we know that a lot of women are now given bone treatment when they're put on them. But I know from what you've told me is that some women haven't been. So again, it's still pretty variable, I think, isn't it?
Yeah. Let's talk a little bit about the real problem here, because when we hear, well, you might have a fracture, or 50% of women have a fracture, and if you're in early menopause, that number might be even higher. What does a fracture mean? Is it just a broken bone, or does it lead to other complications? Because,
So,
if I just break my elbow, it's actually, I'm thinking, well, I've survived cancer. That's all right. If I just
yeah.
break my elbow, it's all right. I manage.
No, absolutely. And this is again, so because I'm a GP, so I see a lot of older patients. And so when you're younger, this isn't really something that you think of. Oh, a fracture. This is when when my son fell off the climbing frame and he broke his arm and he was back functioning again a week later. He was absolutely fine. But actually, the fractures that we get in older people are serious fractures. So, and we particularly talk about the two types of fractures that we particularly worry about. One of them is hip fractures, and one of them is vertebral fractures, so the vertebrae are the bones in your spine. So hip fractures, we know that when they happen in older people, they actually have got a really high mortality. So we know about 10 to 20% of people who've had a hip fracture will die in the following year. So this is a really big number. And we also know that about 50% of them by the end of the year will not be in their previous level of accommodation. So they will not go back into their own home. And that is because of all sorts of different reasons. The other thing that we see is vertebral fractures, so spinal fractures, and these can happen. These are what we call low impact fractures. So as the older people, so this whole idea of the little old lady, so older people get smaller and smaller, and the reason that some of them get smaller is because their vertebrae, the bones that hold up their spine, are actually collapsing. And for many people that happens with no pain, but for some women that can be really painful and really significantly impact on their quality of life. So for instance, I saw a patient as a GP a few weeks ago. She was a fit, mobile 80-year-old who was walking up hills every day, and she was doing some gardening and fractured 3 bones in her spine just from, bending over. And now she is on a frame, can just about hobble around the house, and is in a lot of pain. And hopefully it will get better, but that's really significantly impacted her quality of life. So these are things that don't tend to happen to younger women, although they can. But actually, the real problem is when they happen later in life. They can really affect the ability of people to cope at home and to be able to lead a normal, active life, which is what we always all want for ourselves when we're older.
Yeah. So it's the early menopause that is a risk factor. People that have gone through chemotherapy, is there a risk to their bones?
So interestingly, so specifically when we look at, and again, it's whether it's an effect of the chemotherapy. And again, I'm not an oncologist. I don't know enough about different types of chemotherapy to know that. But as far as I'm aware with breast cancer, which is what most of the patients we see in our clinic have breast cancer, there is some potential effect of chemotherapy, but most of the effect they think is the effect that it has on bringing on an early menopause.
Okay.
But there is possibly some independent effect of chemotherapy as well.
Mm-hmm.
The other issue is with the hormonal therapy, so the aromatase inhibitors. And so we know that aromatase inhibitors, the way, and these are drugs that are given, as you know, after breast cancer in order to prevent recurrence. And they work by completely wiping out every bit of estrogen in your body and essentially putting you into a sort of extreme menopause. And so we see people get lots of muscle and joint side effects with that, don't we? Sort of people get muscle pain and joint pain. But what they also do is they sort of hasten, they kind of exacerbate this loss of bone density that you get after menopause. And so, again, there's a lot of guidance that says that women who are put on aromatase inhibitors should be having DEXA scans when they start them. But again, as far as I can see, firstly, a lot of women are waiting a year or two for a DEXA scan, so are started on it anyway because they have to be, or sometimes this isn't being done. But these are, it's the women who are young and who are having chemo or ovarian suppression, and it's women who are having aromatase inhibitors, and these are the biggest risk factors. But the other thing is some women start off with a high risk. So if you are already at high risk, then you should be, so this is, we need to be thinking about these women. So, and do you find that the women you're talking to are aware whether they're at high risk or not of osteoporosis?
Some have worries. So some women come into our conversations and they would say, gosh, my mum and my granny, both of them had osteoporosis. Both of them had serious complications with fractures. I'm aware this is in my family. How do I know am I at higher risk? I've now had cancer treatment and I really worry about my bones. And for these, their worry, whether it's rational, I don't know, because I have no idea about their medical sort of situation, but their worry about their bones often is their main worry. Yeah. And so they will say, I'm really worried about my long-term bone health now, and I'd really like treatment. And I want to see if I'm a good candidate for maybe HRT, and no one talks to me about it because I've heard it can help. And to us, it always highlights that no one really talked them through all of their options. They don't know if they're at higher risk, and so they worry. And often when they're then down the pathway that they get to see a specialist, they might have their bones looked at. A lot of their worries they're fine because they might have been told, well, we can manage this in certain ways. And so we often find that the worry is bigger in people that when they don't actually know if they are at higher risk. Whereas if they are at higher risk and someone sort of holds their hand through the process, they're okay because they know what they can do about it. If that makes sense. Yeah.
Yeah, I so agree, and I think there's and this is where I'd really recommend to the women that you see to the Royal Osteoporosis Society website, because it's got amazing resources on it. But they also have something called a risk calculator. And the risk calculator is a little bit like this score called FRAX. And FRAX is a score which we do to try and work out which women are at high risk of fracture. And it contains lots of different risk factors in it. So we know that women who have got a very low weight are at higher risk of fractures than others. We know, as you mentioned, a family history, especially a family history of hip fracture, is a strong thing. But we also know that some underlying medical conditions, so celiac disease, for instance, rheumatoid arthritis, having a high alcohol intake increases your risk, smoking increases your risk. So these are all put into this risk calculator. And the other thing is anyone who's taken a lot of steroids. So these aren't the steroids, not the muscle building steroids, but the steroids that you take for things like rheumatoid arthritis, like asthma. So high doses of oral steroids that can also affect your bones. And what you do, and you can go on to that website and have a look, or you can actually go onto the FRAX website. It's FRAX. That's meant for doctors, but actually it's pretty easy to work out how to use it. And that will generate a risk of fracture. And then you can take that through to another website called NOG. It gives you a little button to click on, and that will show you whether you would fall into, it gives you a little graph and shows you whether you fall into a treatment zone or not. And these are things that you can take to your GP to discuss with them. But as we know, unfortunately, the level of knowledge among GPs also really varies.
So I'm going to link to both of those resources because I think they're helpful. Is it helpful for us to do our own fracture? If I go onto the Royal Society for Osteoporosis, could I just enter all of my information and then it might tell me I'm at higher risk or at lower risk? Do I then take that information to the GP or back to my clinical nurse specialist or back to the oncologist? And what do we do with that information?
Yeah, absolutely. And so it depends on if you are someone who is high risk because of your cancer treatment. So for instance, you are just about to start an aromatase inhibitor and you've done the risk calculator and it says that you, because your mother had a hip fracture, you are at higher risk than others, then absolutely I'd be saying to your clinical nurse specialist, no one has discussed my bones with me. I'd quite like to have a discussion about this. Could I have a DEXA scan? So what a DEXA scan is, it's a scan, it's a very simple scan. You just lie on a table and they pass. It's like a sort of very low level X-ray basically, and what it looks at is how thick your bones are, basically how dense they are. Um, and again, in my area that I work in, it's about a 2-month wait for a DEXA scan. But I was talking to a friend who is in Scotland, where it's an 18-month wait for
Wow.
a DEXA scan. So it is very, very variable. But what we would say is either yes to your clinical nurse specialist or to your GP and say, look, I've done this. This is identified that I'm at high fracture risk. Please, could I have a DEXA scan? And if you are at high risk, then definitely in my area on the NHS, you are entitled to one via the NHS. So if you've got any of these risk factors, like an early menopause, like a maternal, or especially maternal, but any family history of hip fracture, those kind of things, then you can get a DEXA scan. And the DEXA scan should be enable your doctor to calculate your actual fracture risk. So that's a better way of telling what your fracture risk is, because now you've got even more information. We know if your bones are thinning in your back or in your thigh bone, in your femur.
There is a bit of complacency, I think I feel sometimes from the medical professional, because I've got a very good friend and she was in an early menopause. She was on tamoxifen, so a drug to keep her breast cancer at bay, and she did that for 5 years. And then she had her ovaries removed. She didn't want to have her ovaries switched off with an injection, so she opted to have her ovaries removed. And we were talking about our experiences and really sharing and encouraging each other to have our cholesterol checked and, to really look after our long-term health. And it's been really a lovely journey we've gone on together. And at one point she did have a DEXA scan and it showed that she had osteoporosis, but her oncologist who ordered the scan, she was under private care, and so she felt very well looked after, didn't really act upon, osteoporosis, early menopause, kind of like expected it. And a couple of years later, her next DEXA scan showed she had the first one she had osteopenia, so the pre-state to osteoporosis, and the second one it showed that she had osteoporosis. And at which point she was very upset because she said, I've done all of this. I've done all of this cancer treatment. I've been a really good patient. I've had my bones looked at. Why did no one do anything about it when I had osteopenia? Now I'm not even 50, I've got osteoporosis. She was really upset. What can someone do if you are diagnosed after this DEXA scan that you've already got thinning of the bones? What do we do?
And you're right, it's really difficult because also there's very little evidence about what you do for people who've got osteopenia. What we do,
Aha.
what we should do, but actually, if you think so, all the effort, this is all the effort in preventative care in the UK in general practice, especially goes into cardiovascular stuff. It's all about reducing your risk of diabetes and heart attack and stroke, and that is where all the the money and all the preventative care is going into. But no one is talking about preventing these really severe fractures which happen in the
Yeah.
future, which are equally as impactful as having a stroke, for instance. So, and it's really amazing when you look at it and you think, why are we not? And these are women, even women who haven't had cancer. Why are we not screening women for this? And interesting, the reason why is because there are certain conditions that a test has to fulfill before it can become a screening test, and the DEXA scan isn't accurate enough. And also, we don't really know of the impact of starting to treat women so early. But it's still in the US, they screen. So they will screen women at 65, but women who are high risk, like the women we're talking about, will be screened at 50. And so, again, what I'm really trying to encourage when I teach GPs is that when women are coming to see us to ask for their HRT, or they're coming to see us to talk about menopause, that we should be thinking in our heads, do you have risk factors? Do you need screening? But what we need to be doing is giving women advice. And there's lots and lots of things that women can do to help strengthen their bones. So there's all the dietary stuff, and then there's the exercise. So those are the two big things. And are those things, do you think, that you'd be interested in, that the people who are listening to this will be interested in hearing a bit more about? Shall we go
Definitely,
through
because
those?
I feel like this particular friend, for example, it was sort of said, oh, now your bones are starting to thin, you've got osteopenia, but I don't think there was a plan. And so she felt she was then not doing anything. And then she was really quite upset that she was sat there, not even 50, and she's got osteoporosis. And so I think it would be so good to think, what can we empower ourselves to do on a daily basis? And when does our doctor need to step in? Are there medications, for example, to help us build bones? But I think if we're left to our own devices, everyone will go out and buy a calcium supplement because we would think maybe that might help. But let's look at what we can do. I'd love that, please. Yes.
Yeah, absolutely. So again, and what we would say to anyone, and again, if you feel that your GP or whoever is not quite up to date with the guidelines are called NOG, NOGG, and these are the guidelines for doctors, and they are relatively new. They were sort of updated a few years ago. So this is something, but they have some really, really good summary of the evidence on this. So the two real dietary things that we talk about are vitamin D and calcium. So that we know vitamin D and calcium are both involved in making your bones stronger. And we know that vitamin D, most of it actually comes from the sun. So we make about 80% of our vitamin D in the skin from sunlight, which is a bit of an issue if you live in the UK because we don't get very much of it. And we don't get enough of it in between October and April to make enough vitamin D. So we are all slightly vitamin D, what we call insufficient, during the winter months. And so if you look at the NHS guidance, what the NHS guidance says is that everyone, high risk or low risk, should consider taking a vitamin D supplement, especially during the winter months. And then during the summer months, I think it's about 15 minutes a day outside without sun cream on, because what the sun cream does is it blocks the UVB, which is what makes your vitamin D. So if you're wearing loads of sun cream, you won't get skin cancer, but you won't get the vitamin D either. So a lot of people will take that as a supplement. You can get it through diet. So it's in things like oily fish and in eggs. And then some foods are fortified, some cereals, but actually it's pretty hard to get all the vitamin D you need through diet. So most people will take a supplement. There's no evidence that taking these super high dose supplements is actually any good. You need about 10 to 20 micrograms, which is 400 to 800 units. If you're at high risk, so again, many of the women that you're speaking to would say an 800 units, and that you can just buy that over the counter. That's really easy to get. Calcium, again, you can get through diet, and we try and encourage people to get that through diet if possible. And again, Royal Osteoporosis Society, they have a calcium calculator, and a calcium calculator you look on, and it's really interesting. There are some really bizarre foods like dried apricots that have got loads of calcium in. So if you're someone who can't eat dairy, and this is what we really worry when people come in and go, oh, I don't eat dairy, I've cut it out. And a lot of people do, because either it makes them feel ill or they just are intolerant. And so we know that soya milk, interestingly, does still have calcium in, but there are other ways of getting calcium. We know that taking calcium supplements on their own, there is some evidence that might increase your risk of having a heart attack. So because they might deposit in the wall of your arteries and make your arteries less stretchy. We also know that if you take very high dose calcium, it can increase your risk of kidney stone. So what we say is ideally vitamin D supplement over the counter, calcium through diet if you can. However, if you're taking bisphosphonates, so bisphosphonates, which we'll talk about in a bit, which are the medications that strengthen your bones, you may well need more calcium than that, because you need lots of calcium so that the bisphosphonates can take it and put it in your bones. And for some people who are definitely having these sort of high dose bisphosphonates, might be advised to take a calcium supplement alongside their vitamin D.
Let's talk about those bisphosphonates now, because I think a few years ago when I was doing workshops, no one spoke about them much. And now some people will say, oh, Danny, I did ask my oncologist whether I could have a bone density scan, but they refused. They said, no, you don't need it because you're on the bisphosphonates. So what are these medications, and would they have helped my friend? Because I think my friend is about to start them, I think. So tell
Yeah.
us more about those. Yeah.
So what they do, so these are medications and they affect, so we were talking about the osteoclasts that break bone down and the osteoblasts that build bone up. And after menopause, what happens is the balance goes wrong. So the osteoclasts are much more active, and so they break down a lot of bone and it's not built up. So what bisphosphonates do, is they affect the activity of the osteoclasts. So they calm them down a bit, and they stop them eating up all the bone, basically. And for women now, especially younger women who are having ovarian suppression, and for some women who put on aromatase inhibitors. So again, this will all be up to your local oncology guidelines and pathways. They are given high dose bisphosphonates, so zolendronate. They're given that as an injection. And they are given that for some time. It depends on the pathway you're on, what chemo you're having. So sometimes for 2 or 3 years, that will be given regularly. And that's a sort of high dose bisphosphonate. Other women who are at lower risk will be given a weekly bisphosphonate, so things like alendronate, and that would be the sort of older women who've got osteoporosis, and that's being treated like that. So again, it depends on the guidelines and pathways as to what you'll be given. But you're right, and I know that the recent workshop we did, there were lots of women talking about having, I think it's Zamita is the brand name, and having these injections.
And if I look at some of the comments we've had recently when I said, let's talk bone health, what do you want to know? In preparing to talk to you, someone said, I have Zamita infusions every 6 months. So that's obviously, she has to probably go to hospital or GP to have those, I'm assuming, Olivia, is that right?
There'll be a hospital, yeah, the hospital would do those.
But she experienced really bad flu-like symptoms every time. She's had 2 now. Is that a common side effect? And how does it differ to those people who take tablets themselves?
Yeah, absolutely. So we hear this all the time on people on Zamita. You can, especially for about sort of 24, 48 hours afterwards, you get exactly sort of feel really flu-like. You can get joint and muscle pain. Some people feel really unwell. And I heard, and it was interesting, I was listening to a webinar where someone was talking about taking it, and she said, it just threw me right back to the chemo, to the loss of control, to these horrible symptoms. And it just made her feel actually psychologically quite distressed. But the good thing to say is that these are generally temporary. So they last for a few days. And the reason they have it is because it's a really high dose that you're given all at once. When people are taking
Ah,
the regular sort of lower dose ones, so these will probably be older people who've got osteoporosis who are taking them. So the ones that we prescribe, which are the weekly alendronate, it's annoying to take. You take it when you have to take it on an empty stomach. So you have to get up in the morning, you have to wash it down with a glass of water. It often gives you indigestion. So you
ah,
don't get these sort of flu-like symptoms, but it is a monumental hassle. And we know that for a lot of people, so these, not talking about people who are taking it for cancer treatment. I'm talking about the people I'm prescribing it to in general practice. We know that after a year, up to 50% of people have actually stopped taking them without
uh-huh.
seeing their doctor because of the
Mm.
side effects, because they just don't
It's
like taking them.
it's so important to talk about that personal preference and also how do we manage it in daily life? Because it's all very well saying we've got these medications and that can help, but how does it work in practice, isn't it? One person here, Lisa, is saying she's on exemestane, so that's an aromatase inhibitor, and she takes a daily bisphosphonate tablet. She said, I just couldn't face 6 monthly cannulas after everything I've been through, so I opted for a daily dose each morning. She also takes calcium and vitamin D tablets. She still experiences joint stiffness and fatigue, and she has back problems. So she says, oh, when does it end? But it's important to talk about that personal choice where
Yeah.
some people might not want to think about it. And they think, well, actually, one injection once every 6 months is a better option for me, isn't it?
Yeah, absolutely. And I think the really key thing for whatever you're taking is just to really to be offered the chance to have a good talk about the risks and benefits. Because definitely
Yeah.
with the patients I see who I'm treating for osteoporosis in general practice, so who are often older, they are often, we give them this weekly tablet and we say, oh, just take it with a glass of water. We never explain to them really how to take it. We don't explain to them what it was for. And I had a discussion with someone yesterday in my GP surgery who I said, oh, I've come to renew your medication and I noticed you haven't had it for 6 months. And she said, oh, I'm not really sure what it's for. Like, I don't feel any better when I take it, which actually is quite a rational. She said, well, it doesn't make any difference to me. So
Yeah.
really explain to people that this actually isn't going to make you feel any better now. But what it's going to do is prevent something that's going to happen decades in the future. I mean, it doesn't make it sound particularly exciting or useful, but a
Mm.
good explanation will make a patient feel empowered to make, as you said, make a choice that is right for them.
Mm. And I do meet a lot of younger people who already have a diagnosis of osteoporosis, and they don't worry about it. Some people do worry about it, and others do brush it off a little bit because they can't feel it. It doesn't impact them today. Um, Partly we're trying to live in the moment and we're not trying to worry so much about the future. But more and more people are getting diagnosed younger, and many are surviving cancer for many more years than even 10 years ago. So it may present a big problem. So it's a difficult trade-off, isn't it, for the person navigating this?
Yeah, I absolutely agree. I think it is a really difficult trade-off. And it's exactly, and also you don't want to, and again, I talk to women who've, as like you do, talk to women who've had cancer all the time. And they often, when they finish the active treatment, they don't want to be constantly reminded of
Mm.
it and having to constantly think about their health and think about this and take more medication. They just want it to all be over and done with and to stop taking these medications, because we do know, unfortunately, that there are some serious side effects of bisphosphonates. And I think just to reassure people who are listening to this is that these side effects are extremely rare, but they just look quite horrible. And there are lots of horrible photos on the internet. So the two things that people worry about is there's this very nasty rare side effect called osteonecrosis of the jaw, which is when a little bit of the bone in the jaw sort of dies, essentially. And it's not very nice. And it often happens in people who are having dental treatment, because they'll have a sort of implant or something and the bone won't heal around it. So what we do often ask is for women to have dental treatment before they go onto a bisphosphonate. But as we often know as well, again, a patient I was talking to last week, he said there aren't any dentists. There are no NHS dentists. I can't access this dental treatment. So then you have a sort of, well, what do you do with that? So
Yeah.
that's also a problem for people. Again, it is very rare, and that is just really reassuring. The other thing that people worry about is that when you've been on bisphosphonates for a long time, because of the way that they affect the bone, it can end up remodeling the bone in a slightly different way. And you can get these funny fractures in your femur called atypical fractures. And they are really unlikely. But the thing to say is they are much less likely to happen than an osteoporotic fracture,
Yeah.
because your osteoporotic fracture risk has been reduced by taking bisphosphonate. So
Yeah.
it's about risk benefit balance. It's about good explanation. It's about being able to make a decision.
Mm. In the UK or in the US, for example, is there one guidance that tells us when a cancer patient should be offered a DEXA scan? Or is it a little bit hit and miss and it depends what doctor you see? Or is there one guidance for
I
everyone?
couldn't
No.
find it. And again, I'm not an oncologist. So I did talk to, Alison. I talked to Alison Macbeth, who is as I'm sure many of you will know her. She works with you a lot, doesn't she, Danny? And she is a cancer. She works in a cancer unit, a breast cancer unit attached to a hospital, and she's a menopause specialist GP like me. And I sort of said, is there any real guidance? And she said, it's just very variable, essentially.
Okay.
So it's very local rather than sort of national guidance. There is some guidance that I read, but definitely from talking to you and from talking to other patients, I'm not sure it's being followed everywhere. So some guidance says everyone should have a DEXA scan. Some guidance says everyone should have a fracture risk, have a FRAX.
Mm-hmm.
And then only the high risk women who are high risk with a FRAX score should have a DEXA. And again, some women aren't getting a DEXA, as we know, because the wait is a year or two where they are.
And so this person here is saying she's on an aromatase inhibitor and she's taking Zodalex to switch her ovaries off. She has zoledronic acid every 6 months. She's never had a bone scan. So do you think in someone like her doctor might have thought, well, because she's on the infusions for her bones, we may not have to do a bone scan? Do you think that's the thinking here? Or
Yes, absolutely. I think
okay,
with that, the thinking is you're on such a high dose of bisphosphonate anyway that
yeah,
actually there's no need for a bone scan. And the other thing is, what no one would want to do is delay treatment. So they'd be, if it's going to wait a year, they'd rather just get you started on the treatment, then you're started on the treatment. So I suppose the question is then is, when would you want a bone scan? So,
yeah,
in 5 years' time, would you want? And again, I couldn't find any guidance that said this is when we need it. I suspect if I was in that position, that I would want, when my treatment had finished, I would, especially if you'd gone into then, because as we know, what happens is for many women on breast cancer treatment, if they're young and their periods stop, they often won't come back. And then I would probably, about 3 years afterwards, I'd probably want to check my bone density, just because we know it takes DEXAs, it takes ages to change.
Yes.
We know we don't do DEXAs very often, probably every 2 or 3 years, because bone density declines very slowly. But I think for my peace of mind, I'd probably want a DEXA scan a few years after my treatment had finished. I don't know if that's based on any evidence at all, so that might just be complete nonsense. So, but that's
Yeah.
how I feel as a patient, I think.
But it is so important that if you've got this nagging worry, for example, or
Mm.
you've had people in your family, or you really now start to worry about, am I doing enough, to just go and be that a little bit difficult patient and do knock on a few doors and see how far you can get. If it's something that you are concerned about. I think we talked about diet, we talked about calcium. I did that calcium checker on the Royal Society for Osteoporosis, and I was quite low in my calcium, and I did think, oh, my diet is very good. So that was a good wake-up call for me to look at my diet like really holistically, because often, you know, there's a lot of focus on eat more protein and eat more this in the menopause space, or and so it's very easy to forget about how many veg and other things you have to eat for that calcium. So it's a good reminder. Can you exercise your way to better bones? If I wear a weighted jacket, if I do my squats, if I pick up my weights, could I make myself better bones?
Yeah, absolutely. And again, there is evidence that and there are two different types of exercise that we talk about. And the first is weight bearing exercise. So what we know, so obviously your bones are bearing your weight all the time, but we know that if you put weight on your bones, they grow back stronger. And so this is what we call impact exercise. So interestingly, things like swimming and cycling don't count, because most of your weight is being held up either by the water or by the bike. They're still good for you. They're good for your muscle strength. They're good for your cardiovascular fitness. But what we talk is anything that essentially presses down on your bones. And so the Royal Osteoporosis Society look at what they call low, medium, and high impact exercise. So low impact exercise is something just as simple as marching on the spot or walking up and down the stairs. And these are, especially if you are someone who is, again, for our older patients who've already had fractures or who have got very weak bones, we would start off with the low impact exercise. Most of the women that we see are not in that position. They can do the moderate impact. And so the moderate impact, things like skipping, interestingly, jogging, especially if you're varying things, so fast and slow, dancing, brilliant way of exercising. And I know we've talked about it before, it's about finding a bit of something exercise that you like, that you want to do. And even things like, and then you get onto the high impact, and that is things like, you know, star jumps, or, you know, playing volleyball, or all these sort of things. Most people will be at the medium impact. And what they say is thinking about trying to get about 50 impacts a day. So it's even just,
Oh, wow.
just jumping off the bottom step 50 times, anything that sort of bangs your bones and makes them, and aiming for about 50 on most days. And what we would say, so some of the women that I see who are older are not getting much exercise at all, and that means they might have arthritis, or they might have a disability. Even just getting up, walking around the house, stamping your feet while you're waiting for waiting for the kettle to boil, anything like that is going to be putting impact on your bones and helping them to grow back stronger. So that is the impact exercise. And then the other thing is about strengthening your muscles. So we know that muscles pull on your bones, and as they pull on your bones, again, they compress your bones a little bit and they help them to grow back stronger. So the more muscle strength the stronger your muscles are, the more they're going to do that. So you can maintain your muscle strength and your flexibility by doing things like yoga and Pilates. But to actually increase your muscle strength, you need to be really using weights, and that is weights that are gradually increasing in the weights that you're doing, or increasing the number of repetitions. And what we do say, this is when it's really worth actually seeing a professional who knows about
Yeah.
this stuff. So interestingly, people always think that personal trainers are going to be like 25-year-old blokes who are going to be telling you to like bench press massive weights, but actually there are loads of personal trainers out there who are women in midlife who are specifically set up, strength and resistance exercise classes. Is that worth it? But also through your GP. So we do a local gym referral, and osteoporosis is one of the things that is listed on the
Oh,
gym.
brilliant.
Yeah, so you can go to a local gym, you get 10 free sessions. And with any gym, when you first go, you should have a session with a personal trainer who will show you how to use the weights and who will construct an exercise plan for you.
And that is key, isn't it? Because I know there is a lot of worry for people who already have osteoporosis, and rightly so, of how to exercise safely. Because as soon as you start picking up weights, people have questions. How do I do it? Do I do it rightly? How heavy should my weights be, or other exercise? And I just know from even a yoga practice is forward folding when you're rounding your spine isn't always advised for people with osteoporosis. And there are other ways of maybe hinging at the hips and keeping a longer spine. And so I think it's so empowering to think, yes, exercise has all these benefits, but how do we do it safely? And most people need help because we are no exercise specialists. We are patients and we're just trying hard to do our best. So I think if anyone can reach out to exercise specialists, we've got a few in our Facebook group. There's also Can Rehab. They train exercise specialists, especially for cancer. They're a charity and they've got exercise specialists in the whole country. So they might be worth looking at as well.
Yeah, absolutely. And there are some brilliant videos on the ROS again website, same one.
Oh.
They've got some great videos about how to do strength training, how to do resistance training, all of these kind of things, because it's not only about what you can do to strengthen your bones. It's the fact that, and again, none of us want to think about getting older, but what we're also trying to do is reduce the risk of falls, because it's falling over that makes you fracture. So it's about, and all of us want, when we're older, to be fit and active and living in our own home, and being able to do things for ourselves. And so any exercise is about that, essentially, is also about really making sure that you're living what we call a healthy old age, essentially.
Yeah, there will be many people that have listened to this conversation now, and they might be a little bit specific in their case. They might have a different cancer or a cancer treatment we haven't mentioned or we haven't gone into detail. Do you think their best starting point is to go back to do the fracture risk? And I'm going to link to it in the show notes and get the ball rolling and just see where they're at. Do you think that's the first thing people can do to take action?
Yeah, absolutely. But I would also say is that it's going to be very difficult to know whether your individual cancer treatment has affected your bones, because a lot of chemo doesn't affect your bones. So this isn't something that is going to come into your treatment plan. So this is where you need to talk to your oncologist. I mean, cancer treatment changes so quickly. The stuff that was around when I was learning about cancer treatment, which was 20 years ago, isn't around now. There's lots of new things. So it's just about saying to your oncologist or your cancer treatment, does this medication affect my bones? If it does, is it worth having a DEXA scan? Because although the fracture risk calculators are great, they can't include every risk. They won't have your specific treatment in that. So again, it is really worth doing the FRAC score. That's a really good thing to think about, but also to really have a word with your oncologist or your nurse specialist.
And also to maybe get a second opinion. I'm sorry, I love all of you amazing doctors, Olivia, but when I speak to more and more women, I sometimes think it's so helpful that when we maybe haven't had the answer that we needed, that we could go and knock on someone else's door, because also at the time of inquiry, we're a different patient. I recently spoke to a lovely author of a book, Rosamund Dean. She's written a book after her breast cancer treatment, and she's also a journalist. And she said when she first discussed, for example, HRT with her oncologist, it was an absolute no-no. And that was, when she was going through active cancer treatment. And then 4 years later, when she was planning for a surgery, the surgeon said, oh, you should maybe consider HRT because of your bones and everything. And so she went back to her oncologist, and it was a totally different conversation, of course, because she was 4 years on and a different patient, and she wasn't going through active cancer treatment. And so I also think depending on when we speak to our doctors, we will get a different response because we're at different stages. But if you're still curious, go and knock on anyone's door, because I feel like people always deserve the answer It's never too
Yeah.
late, isn't it? Especially with
Absolutely.
bones.
But
Never
also
too late.
things change. If you think, 5 years ago, we weren't talking about HRT at all.
Yes.
So, exactly. So if things have changed, things change medically as well. So if things change in what we're talking about, in what we know about, there's new research comes out. So again, if you're sort of looking up and if you're thinking, actually, wait a minute, I've looked this up online and it does say that my cancer treatment that I had 5 years ago could have affected my bones. It is worth then exploring that, because it may well be at that point no one knew it, but they do know now because there's been new research. So there are, hundreds of bits of research coming out every day. So things do change with time. But you're right. Unfortunately, the answers that people get are so variable depending on who they talk to and what their level of knowledge is.
On our last workshop, Olivia, the one we did where we had lots of patients join us, lots of people said, oh my gosh, I've learned more in 40 minutes listening to Olivia than in 4 years managing this on my own and trying to find the right information from the GP. And I really do believe this sort of little episode today on just the focus on bones is going to be so helpful for so many. And thank you so much for your time. It's always empowering to talk to you. I recently bought 5 kg weights. They're quite heavy for me, Olivia. And I don't have a plan. I don't have an exercise regime, but they're in my kitchen. And every now and then I pick them up or
Yeah, no, absolutely. That's a really good start. I know I've got mine are less, mine are 4 kg. And
yeah.
I found a little YouTube video of someone who does just a 30-minute weights workout.
Yeah.
And it's all really kind of benign. You just do a few squats holding your weights, but it
Yes.
makes me feel that, I'm doing something good for my bones. My mum's got osteoporosis. She's had fractures, so it is something I think that, I'm 50 now. It's something that we start thinking about. And so
Yeah.
we all need to be thinking about our bone health and our bone strength.
Yeah. Well, I'll be sending you a little selfie of me with my weights very soon. I'll expect one back. I sometimes even carry my teenage children, and I think they're probably my weight now. They're as heavy and big as I am. And I just carry them on my back and I pretend to do a few squats, just showing them I've
Excellent.
still got it.
Yeah, that sounds absolutely
Proper.
perfect. Yeah, absolutely. That and jumping down the stairs. There we go. I know now
Brilliant.
loads of people with sprained ankles from sort of jumping off the stairs and things. So
Yeah.
do be careful. Yeah,
Yeah.
do consult your doctor before starting an exercise regime. No, but really, really have a look at the ROS website is so good for everyone. And I think just one quick point though, Danny, what you said, which I think is so true about if you do have osteoporosis, do be really reassured that you can still do everything that you want to do. As you said, you do have to modify things, but it doesn't mean you can't exercise. So I do see women who are just terrified, but of course they are. They think, oh my God, if I do anything, I'm going to break something. But actually, most women can do that moderate intensity exercise. It's only the women who were sort of older had lots and lots of vertebral fractures that would be saying maybe just the low intensity. So again, this is where it's worth consulting someone who's professional, who specializes in exercise, who can give you a hand with that.
Brilliant. Thank you. Thank you. Thank you. Thank you. I've got 3 links to go into the show notes so people can take that first step and we can make this a really action-driven episode, which I love nothing more of, and people to go and do their fracture risk or have another conversation with the doctor. Thank you, Olivia. And I can't wait to chat soon. It's amazing,
Brilliant.
everything you do. Thank you. Thank you.
That's no problem. Thanks very much, Danny.
I hope this episode was really helpful for you. It's one of those practical episodes that I love getting out to you. In the show notes, go and find Myla Health. This is where you can find Dr. Olivia Hum. This is where she practices. I've also linked to the fracture risk calculating tool that we spoke about, the Royal Society for Osteoporosis, and the NOG guidelines on the guidelines for osteoporosis and the treatment, which are really helpful links to share with your doctors and your treatment team should you need to. And do go back to all of our other episodes on this show. We're over 150 episodes in. We talk about everything from diet to sexual health. If this is the year or if this is the time where you are doing more exploring about your options of how to feel better, how to recover, I hope this podcast is a really sort of a guiding companion for you and your recovery. I'll see you on next week's show and I can't wait to dive into another exciting topic.